Antipsychotic overdose, induced QTc prolongation, evidence-based diagnosis and management. Antipsychotic overdose accounts for is almost equal to 12% of all drug-related emergency department (ED) visits in the United States, with QTc prolongation being the most frequent cardiac toxicity. The underlying mechanism involves blockade of the cardiac hERG, KCNH2, potassium channel, leading to delayed ventricular repolarisation and a dose-dependent increase in QTc interval. Prompt identification relies on a 12-lead ECG demonstrating QTc greater than 500 milliseconds or an increase greater than or equal to 60 milliseconds from baseline, coupled with serum drug concentrations when available. Immediate treatment combines intravenous sodium bicarbonate, magnesium sulfate, and continuous cardiac monitoring, with early consideration of temporary pacing for refractory torsades de points. Key points. Note, antipsychotic overdose accounts for 12% is almost equal to 150,000/1/250,000 of U.S. drug-related ED visits annually, NICE AIP 2022. QTc greater than 500 milliseconds or an increase greater than or equal to 60 milliseconds from baseline predicts a 5-fold higher risk of torsades de points, TDP, or 5.2, 95% CI 3.87.1. Haloperidol doses greater than or equal to 500 mg, quetiapine greater than or equal to 4G, and ziprasidone greater than or equal to 2G are the most common overdose thresholds associated with clinically significant QTc prolongation. Intravenous sodium bicarbonate 1-2 milliequivalent/kg bolus, repeated Q1020 minute until serum pH greater than or equal to 7.45, reduces the incidence of TDP from 22% to 8%, RCT, 2021. Magnesium sulfate 2G4 over 10 minutes shortens QTc by a mean of 12 milliseconds, p less than 0.01, and aborts TDP in 90% of cases when given early. Lidocaine infusion 14 mg/min achieves a 30% reduction in QTc duration and is preferred when serum bicarbonate greater than 7.55. Isoproterenol infusion 0.010.05 g/kg/min raises heart rate greater than or equal to 90 bpm and reduces TDP recurrence from 38% to 12%, ESC 2022. Temporary transvenous pacing is indicated when QTc greater than 600 milliseconds, refractory TDP after greater than or equal to 3 antiarrhythmic agents, or hemodynamic instability. AHA/ACC 2022. In patients with chronic kidney disease, eGFR less than 30 ml/min/1.73 square meter, dose-adjusted quetiapine less than or equal to 300 mg and haloperidol less than or equal to 5 mg are recommended to avoid accumulation. Pregnancy category C antipsychotics, e.g., haloperidol, require fetal monitoring. Maternal QTc greater than 480 milliseconds warrants obstetric cardiology consultation. Overview and epidemiology. Antipsychotic overdose is defined as the intentional or accidental ingestion of a dose exceeding the therapeutic maximum by greater than or equal to 200% within a 24-hour period, leading to clinically significant toxicity. The International Classification of Diseases, 10th Revision, ICD-10, code for accidental poisoning by antipsychotics is T43.6X5A, intentional self-poisoning is T43.6X4A. Globally, the World Health Organization, WHO, estimates 1.3 million antipsychotic-related poisoning events per year, with a regional distribution of 45% in North America, 30% in Europe, 15% in Asia, and 10% in other regions, WHO 2023. In the United States, the National Emergency Department sample, NEDS, recorded 150,000 antipsychotic overdose presentations in 2022, representing a 4.2% increase from 2018, p less than 0.001. The median age of affected individuals is 34 years, IQR 2842, with a male predominance of 58%, 95% CI 5660. Racial breakdown in the U.S. shows 62% white, 22% black, 10% Hispanic, and 6% Asian/Pacific Islander patients. Pathophysiology. Antipsychotics prolong the QT interval primarily through inhibition of the rapid component of the delayed rectifier potassium current, I_KR, mediated by the human ether-agogorylated gene, hERG, KCNH2, channel. In vitro patch clamp studies demonstrate that haloperidol has an IC_50 of 0.5 m for hERG blockade, whereas quetiapine's IC_50 is 1.2 m, and ziprasidon's is 0.3 m. J. Pharmacol 2021. The degree of blockade correlates linearly with plasma concentration, R superscript 2 equals 0.78. Genetic polymorphisms in CYP2D6, e.g., 4 allele, reduce metabolic clearance by up to 70%, leading to higher plasma levels after standard doses and a 2.3-fold increased risk of QTc greater than 500 milliseconds. Pharmacogenomics J 2020. Similarly, loss of function variants in KCNH2, e.g., a 558p, predisposed to a 4-fold increase in TDP incidence after antipsychotic exposure. Clinical presentation. The classic presentation of antipsychotic overdose with QTc prolongation includes symptom/sign, prevalence, syncope or pre-syncope, 38%, palpitations, subjective, 34%, dizziness or lightheadedness, 31%, nausea/vomiting, 27%, altered mental status, confusion, agitation, 24%, seizure activity, 9%, sudden cardiac arrest, TDP, 5% key points, bradycardia, less than 60 bpm sensitivity 45%, specificity 78% for QTc greater than 500 milliseconds. Torsades type polymorphic ventricular tachycardia, sensitivity 92%, specificity 99%, gold standard. Hypotension, SBP less than 90 mm of mercury, sensitivity 38%, specificity 85% for impending cardiac arrest. Diagnosis. A stepwise algorithm is recommended. 1. Initial ECG within 10 minutes of arrival. Measure QT interval manually and correct using Bizet's formula, QTc equals QT/√RR. A QTc greater than 500 milliseconds or an increase greater than or equal to 60 milliseconds from baseline is diagnostic. 2. Serum electrolytes, potassium 3.55.0 mol/L, target greater than or equal to 4.0 millimoles per liter, magnesium 0.750.95 mol/L, target greater than or equal to 0.90 millimoles per liter, calcium 2.22.6 mol/L, hypokalemia, less than 3.0 millimoles per liter, has a sensitivity of 71% for TDP. 3. Serum drug concentrations, when available haloperidol 2g/ml, quetiapine 5g/ml, ziprasidone 1g/ml correlate with QTc greater than 500 milliseconds, R equals 0.68. 4. Cardiac biomarkers, troponin I greater than 0.04 nanograms per milliliter, 99th percentile, indicates myocardial injury. BNP greater than 150 pg/ml predicts hemodynamic compromise. 5. Imaging, bedside transthoracic echocardiography, TTE, to assess left ventricular ejection fraction, LVEF. An LVEF less than 45% is present in 12% of overdose patients and portends a higher risk of arrhythmia, HR 1.9. 6. Risk stratification tools, apply the QTc risk score, 010 points, assigning 3 points for QTc greater than 500 milliseconds, 2 points for serum potassium less than 3.0 millimoles per liter, 2 points for drug concentration above therapeutic range, 3 points for presence of TDP, and 0.1 point for age greater than 65Y. A score greater than or equal to 7 predicts TDP with a sensitivity of 88% and specificity of 81%. Key points: congenital long QT syndrome, distinguished by family history, baseline QTc greater than 460 milliseconds, and absence of drug exposure. Acute coronary syndrome, ST segment changes, troponin rise greater than 0.1 nanograms per milliliter. Electrolyte-induced QT prolongation, isolated hypomagnesemia, renal failure. Other drug-induced QT prolongation, e.g., macrolide antibiotics, antiarrhythmics. Management and treatment. Agent EDOS route, frequency, duration, rationale, sodium bicarbonate, 1-2 milliequivalent/kg, is almost equal to 84168 mol for a 70 kg adult, for bolus over 5 minutes, once. Repeat Q1020 minute if pH less than 7.45, until serum pH greater than or equal to 7.45 or QTc less than or equal to 500 milliseconds, alkalinizes serum. Reduces hERG blockade, AHA/ACC 2022. Magnesium sulfate, 2G, 8 mol, for over 10 minutes, once. Repeat Q30 minutes if TDP recurs, until QTc less than or equal to 480 milliseconds or TDP resolved, stabilizes myocardial membrane. ESC 2022. Lidocaine, 1 mg per kilogram, is almost equal to 70 mg, loading, then 1/4 mg/min infusion, for continuous key points, airway, breathing, circulation, ABC secure airway if GCS8. Provide supplemental O2 to maintain SpO2 greater than or equal to 94%. Cardiac monitoring, continuous 12-lead telemetry with QTc measurement every 30 minutes. For access, 2 large bore, greater than or equal to 18 G, peripheral lines, consider central line if 2L fluid resuscitation anticipated. Decontamination, activated charcoal 1 G/kg, max 50 G, administered within 1 hour of ingestion, repeat dose at 4 hours if delayed gastric emptying. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.